Greetings, everyone. Thank you for joining. I'm Dr. Catherine Y. Brown. Today, I'm excited to introduce you to Dr. Aaron Waxman, who is a physician. Welcome, Dr. Waxman.
Well, thank you. Thank you for including me in this project.
I truly appreciate you. I'm on the road to 100 voices of pulmonary hypertension patients, caregivers, medical professionals in the community. And so finding people like yourself that are highly skilled, qualified thought leaders to allow me to share their voices with people all around the world is truly an honor. So for our viewers, can you first just tell them where you're located and a little bit about your background?
Sure. So I'm located in Boston, Massachusetts. I'm at the Brigham and Women's Hospital there and a faculty member at Harvard Medical School. I run the Center for Pulmonary Heart Disease and direct the Pulmonary Vascular Disease program at the Brigham. Excuse me. I've been involved in pulmonary hypertension and pulmonary vascular disease work since really the mid-90s. When I was in training, I was on in the intensive care unit, and that's where all the patients used to go for evaluation. And I just thought it was fascinating what my attending was doing at the time. The only drug, obviously, was Flolan, and the titration was, it was something you didn't do very often, but when you did do it, everybody was very vigilant and worried about the patient because they were all very sick at that time. And I've really been doing it ever since. It was kind of a way of doing outpatient critical care, if you will.
What about the population and what you saw inspired you to do this work? Because some people will tell you it's very rare to have someone with a background such as yours. So what inspired you?
I think it was a mixture of the patients and what they needed, as well as the physiology and what the patients would go through, what we would see with response to the medication, and just the really close management that these patients required.
What is your target age range that you work with or that you see?
So I think one thing that I've always felt important in the programs that I've run, and I was director at Yale and then at Mass General and then at the Brigham, I've always felt we need to be inclusive of all patients with pulmonary hypertension, because as we've learned more and more about the pathology and the pathophysiology, there's a lot of overlap among all of these patients. All the clinical trials have always focused on group 1 disease and even subsets of group 1 disease, but I've always felt like we haven't been there for all the other groups as well. So I think one of the most important things I see is just being inclusive of all patients with pulmonary hypertension.
So for many people that might see this and they don't understand what pulmonary hypertension is, how would you explain that to someone?
Well, I mean, in the very simplest terms, it is high blood pressure in the vessels of the lung, but I think that simplifies it too much, because it's not so much the pressure that is the disease, but really more a sign of the disease. And where the disease gets complicated is when you look at the blood vessels in the lung, they get thicker and they get stiffer, and they get thicker and stiffer in part because there's a lot of abnormal cell growth in the vessels. And over time, as those vessels get stiffer and the resistance to blood flow increases, it starts to affect the function of the heart. And initially, the heart can handle it and adapt to it, but over time, that adaptation starts to fail. And as the right heart starts to dilate and fail, patients get very sick and will die of heart failure if we don't do something about it.
Thank you so much. So this is a random question. On average, throughout your career, how many patients do you think you've treated? And I'm sure there are many.
It's a lot. I mean, we have a pretty large program in Boston where we follow close to 2,000 patients across the spectrum of pulmonary vascular disease. And it's probably been over 1,000 patients that I have taken care of myself. I have 7 other physicians who work with me in the pulmonary vascular program itself, as well as several PAs and then a whole research staff and support staff.
Awesome. What are some of the most recent advances that you've seen in general? Because I remember Flowland, my mother started on that, then she switched. So what do you think are some of the advances?
Well, I think, that's a great question, because obviously everybody talks about how many new drugs there are for pulmonary hypertension, but a lot of them are Me Too drugs. We have 3 pathways that have been targeted for years now. And in those pathways, we definitely have some good drugs. But I think we're entering a phase of treating patients with drugs that will actually modify the disease. Drugs that actually target the pathways that are involved in this excess cell growth and the remodeling that happens. I think sotatercept is hopefully going to come to market soon, and that will have a big impact on how we treat patients. But there are also another number of drugs that are coming down the pipeline right now that I think will have a big impact.
Amazing. So when you say 3 pathways, could you elaborate? Because some people might not know what you're referring to.
Yeah, so the first pathway was the prostacyclin pathway, where we learned patients didn't have enough circulating prostacyclin, which is a very potent vasodilator. Probably has some other effects as well, because clearly patients who've been on it for a long time, some of them do show improvement in their pressures and flows. Within the prostacyclin pathway, I think treprostinil has been a great addition because of the half-life and the stability in room temperature, which just imparts a safety component to it over what we had to deal with Flowland. And then the other pathway, the important 2 other pathways are the nitric oxide pathway, which nitric oxide is probably the most important vasodilator in biology. It's something that's part of our blood vessel function. And oftentimes patients with pulmonary hypertension don't have enough nitric oxide being produced. So we have drugs that enhance the endogenous nitric oxide, like sildenafil and tadalafil. And then we also have a drug like riociguat that increases the amount of nitric oxide available. Actually, it doesn't increase the amount of nitric oxide, it increases the second messenger that nitric oxide stimulates. And then we have the endothelin pathway, and endothelin is a peptide or a small chain of amino acids that we produce in our bodies. It's a very potent vasoconstrictor, and it also causes fibrosis or scarring of the tissue. And we have drugs that block the effects of endothelin.
When you think about the future of healthcare and medicine, what are some of the things that need to be done to get more providers who want to specialize in pulmonary hypertension? Because, I mean, I'm just inspired by listening to just your work, what you're doing, but also your compassion and the way that you just explain things. And so how do we duplicate the Dr. Waxmans in the future?
Well, one thing that I'm really proud of and thrilled about is one of our patients actually endowed a fellowship program. And we, along with Stanford University, have the longest enduring programs in the country right now. Ours is going on 9 years. And, it's a 2-year program, so we're able to train people who have finished either pulmonary or cardiology. Most of our fellows have all gone the pulmonary route, but they're specifically trained over a 2-year period in pulmonary vascular disease. So these are fellows who come to us with already a strong interest, if not passion, for the area. And they spend a year on the clinical arena and then another couple of months plus almost a year doing research in pulmonary vascular disease. There are a growing number of these fellowship programs, really just starting now, but like I said, Stanford University probably has the oldest program, and we have the second oldest.
Amazing. So, what words of wisdom would you have for maybe patients, caregivers, or those that are watching this video?
Well, I think the most important thing, and what also was attractive about pulmonary hypertension patients, is they're a very informed group of patients. The PHA is a great patient advocacy program, and I think patients need to get answers to questions. And if you're not getting the answers clearly, or you're not getting the answers, you need to find another provider. Because you should have all those questions answered. And that's how you find out what are the state-of-the-art treatments, what other options there are to take care of you. Those kind of things I think are critical.
Amazing. Well, I thank you for taking time with me today. I know this is going to be a very informative video for people that are watching. Is there anything else that you want to share, or any information, or how people can find out about the clinic or any of your work? I would love for you to share any final thoughts.
Well, we're easy to find. Like I said, we are probably the biggest program in the New England region, and we're located at the Brigham and Women's Hospital in Boston, and we are happy to take care of anyone who needs it.
Thank you so much, Dr. Waxman. And for those of you who are watching, continue to follow my journey. I'm on the road to 100 voices of pulmonary hypertension. I don't know when I'm going to get there, but I'm going to get there. So until next time, have a great day.